Good morning. Today I will be presenting a case on nutrition support in an 87 years old Chinese female patient who was admitted with infection and developed hyperactive delirium. This patient was admitted on 7th June to the emergency department with a 3-day history of productive cough, fever, and shortness of breath. She stay in private nursing home and is semi-dependent in activities of daily living using a walking stick. She has one adult son and one adult daughter and is taken care by caregiver in ward. She was diagnosed with community-acquired pneumonia, hypovolemic hyponatraemia, iron deficiency anemia with a decreasing HP trend. Hyperactive delirium, likely secondary to infection, treated with haloperidol. She also has underlying of hypertension and ulcerative colitis under follow-up by PPUM on tablet mesalazine 2 gram twice and ustekinumab 90 milligram 8 weekly. She was referred to dietitian on 11 June. Noted doctor wrote for proper diet plan. Upon assessment, she appeared drowsy due to medication and could not follow simple instruction. Estimated MUAC was 23 centimeter. Any height measured 43 centimeter. Calculated height is 145.9 centimeter and dosing weight is 46.8 kg at BMI 22. Upon observation and palpation, showed mild to moderate muscle and fat loss. She wears full dentures and had complaint of abdominal bloating or pain by caregiver. Upon dietary assessment with patient son, intake at nursing home was estimated around 1,110 kilocal per day and less than 40 gram of protein. Her son showed photos of unfinished meals and noted food was often too hard for her to chew. Reported by caregiver in the ward, she refused some meals, especially sweet taste food, which calculated energy intake in ward for breakfast and lunch recorded was just 350 kilocal with 13 gram of protein. No information on weight changes can be confirmed, but Sun said she had lost some weight. Based on assessment, I come up with nutrition diagnosis, which is inadequate energy and protein intake related to decreased ability to consume sufficient protein and energy at home due to hard texture foods served, as evidenced by energy intake at nursing home only met 24 kilocal per kg body weight and protein intake of less than 40 gram per day. Then my main goal was to optimize energy and protein intake with target prescription is 1,400 kilocal, which are calculated to be 30 kilocal per kg body weight, and also 56.2 gram of protein per day, which is calculated to be 1.2 gram per kg body weight. This both energy and protein was based on Aspen guidelines for geriatrics. As for intervention, provided one sachet of ONS, a meal supplement, glucerna, for patient to try and explain, and I explained to carer on how to prepare the supplement. I also encourage oral intake and alter snacks according to patient's preference. In this case, few monitoring parameters should be looked at include diet intake, input-output chart, disease progressions, and blood pressure. On the next day, 12th June, upon first follow-up, noted in case not, her delirium had resolved. She finished her breakfast that day and had no abdominal pain. However, she passed watery stools 3 times in the morning, reported by caregiver. Her diarrhea is most likely due to laxative and antibiotics, which just started yesterday. Caregiver also said that yesterday complaint of abdominal pain was just because she was afraid of passing out stool. And also noted in case not, doctor planned to stop IV fluids and noted discharge plan coming morning. Since patient about to discharge, advice given to caregiver to ensure food with mince and soft texture at home, emphasize on mince and soft texture of protein like fish and chicken. Lastly, I also provide regime of meal supplement to be taken twice per day at snack time, especially when oral intake is reduced or loss of appetite. The two choices include Ensure Gold and Nutrient Fiber if patient having constipation. At 11 a.m., I witnessed caregiver fed patient with the sample given yesterday and noted patients able to finish half cup. Last, for discussion and conclusion, in this case, unfortunately, no data was available on her ulcerative colitis progression. or weight changes due to lack of documentation, caregiver uncertainty, and son's limited visiting hour. Lack of certain part info include weight changes makes SGA scoring is incomplete. However, this case shows how poor intake in the elderly, often caused by inappropriate food texture, which can increase risk of malnutrition. Thus, nutrition support or meal supplement and texture modified diet is crucial to support adequate energy and protein intake, especially for recovery since patient has infection. In conclusion, the role of dietitian is vital in bringing medical management and functional nutrition support in elderly patients. Thank you so much for listening.